in the light of American Academy of Otolaryngology Head and Neck Surgery guidelines. So this is going to be a very simple presentation and it will not take very long. So first with the introduction. So epistaxis, or commonly known as nosebleed. So it will include both bleeding from the nasal cavity, that is anterior bleed, and bleeding from the nasopharynx, that is posterior bleed. So 60% of the population does get nosebleed at some time in their life, but only of all these 60%, 6% will seek medical advice. So only in 6% of these patients it is severe enough that the patient needs medical advice or his quality of life is affected. Of all the emergency department visits, only 0.5% are for epistaxis, but of all the ENT emergencies, 1/3 is epistaxis. So for us this is a very important topic. So epistaxis has a bimodal age distribution. It is common in children less than 10 years and in adults between 70 and 79 years. In children, the most common cause is digital trauma or nose picking. The other causes include crusting from inflammation or presence of a foreign body. And then if you have an adolescent male with unilateral obstruction and bleed, you should always suspect angiofibroma. So a little about the anatomy of the nose. So this is the medial wall of the nose, this is the lateral wall of the nose. So the medial wall comprises of the septum. The most common site of epistaxis is this septum, and on the septum it is this area which is shown in blue, which is also known as Little's area or Kesselbach's area. You can see here that it has a very it is very well vascularized. It has a supply from anterior posterior ethmoidal arteries, from saphenopalatinate artery, from superior labial artery, and a greater palatine artery. So it is supplied by both the internal and external carotid systems. And then this is the lateral wall of the nose. And on this lateral wall, the most important area is this area of saphenopalatinate artery. So the most common site of posterior bleed is this area. So the factors that are associated with epistaxis include long-term anticoagulation that are seen in 15% of the patients, hypertension in 33%, and underlying coagulation disorders in 0.9%. So this brings us to a very common question: does hypertension cause epistaxis? So it is a very common scenario that a patient lands in the ED with epistaxis, and when you check the blood pressures are very high. And now the question is whether the hypertension is the cause of epistaxis, or whether the patient is hypertension because of anxiety associated with epistaxis. So this is still an ongoing debate. Still we do not have the right answer. I will share one systematic review that is quite recent and was published in 2017. On association between hypertension and epistaxis. So they started with around 2700 papers. After screening, they were left with 10 papers on the topic. These are the 10 papers. I want you to concentrate on just this last two tables and on the percentages. So these are percentages of hypertension in patients, percentages of epistaxis in patients with hypertension and the patients who did not have hypertension. And when you see closely, the percentages are quite similar in most of the studies. And I have excluded the forest plot for the sake of simplicity. And when you see the conclusion, the authors say that hypertension has significant association with risk of epistaxis, but this association does not fully support a causal relationship between hypertension and epistaxis. So we know that hypertension does increase the risk of epistaxis, it increases the severity of epistaxis, but whether it is the cause of epistaxis or not, that is still not true, or that is still not proven by evidence. So why do we need guidelines for any topic? So one purpose is to identify quality improvement opportunities in the management of nosebleed and to produce best practices and to reduce unjustified variations in practice of managing epistaxis. So in this guideline, our target patients would be patients aged 3 years and above, and those where nosebleed is either severe, persistent, or recurrent. So these would be those patients who would present to a healthcare facility because of nosebleed, and patients with tumors, with vascular malformations, with facial trauma, and those less than 3 years will are not related to these guidelines. And the encounters where these guidelines apply include both outpatient clinics, emergency departments, hospitals, telephone encounters of patients, emails of the patients, and telemedicine. So briefly about what are the interventions that are usually done for epistaxis. The first line always include direct nasal compression, topical vasoconstrictors, chemical or electrocautery, and nasal packing. So of all the patients that present with epistaxis in an ED, 19.7% will need nasal packing. Of these, majority will need only anterior nasal packing, and a very small number, that is less than 7%, would need posterior nasal packing. And for patients with refractory bleeds that are not controlled by our routine measures, we have two options, that is either surgical endoscopic ligation or angioembolization. So both of these techniques have a really good success rate of more than 90%. And there is a debate which is better than other, but most of the studies show that surgical ligation is more cost effective than angioembolization and is also more easily available than angioembolization. So let's start with the guidelines. So the guideline comprises of 14 action statements. We will not go through all of them, only I will go through a few important ones. So the statement number 2 is on nasal compression. So what is nasal compression? So it is a firm sustained pressure on the lower third of the nose, or you can call it nose pinch, with or without assistance of patient or caregiver for 5 minutes or longer. So the guideline tells you how it is done, where it is done, and it gives you a minimum time duration, not the maximum time duration. So it has to be at least 5 minutes. Anything less than 5 minutes will not be effective. So all active bleeding should initially be managed with nasal compression. आपको ER में मिले, ward में मिले, जहाँ भी, this is the first thing that you should do. And the patient should be in sitting position. There is a very common practice to the family will tell the patient to lie down. That is dangerous, because if the blood goes into the nasopharynx, the patient can aspirate the blood. So the patient should be sitting, slightly the head should be bent forward, and there should be bowl or anything in front of him where he can spit blood. So always start with the simplest, most cost effective, least invasive and effective intervention. So can anyone tell which is the right way to do nasal compression? Yeah? B, yes. So as we have already seen in the anatomy, so what we are doing here is essentially we are putting pressure on the littles area to stop bleeding. And so it is already evident that this is the right position and this is not the right position. So a longer duration can be used. Some authorities recommend 10 minutes of duration, and repeated compressions are helpful if needed. Topical vasoconstriction can be given along with nasal compression. Patient himself or herself or patient's caregiver or the patient's attendant, they can participate in this process, because pinching the nose for that long duration might not be possible for an ED physician who has to look at other patients as well. And then these are some new aids for nasal compression. These are nasal clips. These are not very comfortable, not easily available, but if available and tolerated by patient, these can be used. And then this is 2 tongue depressors joined together. This is an intervention that I have seen emergency physicians doing, never seen it in an ENT department, but there are papers on it, and it has shown to be effective for putting pressure on the littles area. So now it brings us to the statement 3A, that is about nasal packing. So when should nasal packing be done? So if the bleeding site cannot be identified due to the bleeding itself, so the bleeding is profuse, you did compression, usually it will stop with compression, and then you can visualize the bleeding site and address that. But if that does not happen, then your patient needs nasal packing. So the benefits of nasal packing are, it is effective and it gives prompt control of bleeding. You are protecting the airway, and you might avoid transfusion with nasal packing. The harms are mucosal damage. Whenever you manipulate the nose, the mucosa is very fragile. You will definitely end up damaging the mucosa and might cause even more bleed, and can then hamper your visualization of the site later on. There is risk of infection with nasal packing, of course, and you need to give prophylactic antibiotics for that, and then the subsequent examination will become difficult for identification of the bleeding site. And the most important of all, it is a very uncomfortable experience for your patient. So then we come to statement 3b. So nasal packing in patients with increased bleeding risk. So nowadays we have a lot of patients who are on antiplatelets and anticoagulation, and they do present with nasal bleeding in the emergency department, and then sometimes you can have a patient with bleeding disorder. So the highlight is always use resorbable packing in these patients. Never use the traditional ribbon gauze that you have to remove later on. I will show you the resorbable packings in the presentation. So what happens is that it avoids further bleeding associated with removal of the packing, because these are resorbable. You can put them in the nose and you don't have to remove them. And the harms or side effects associated with these are similar to conventional packing, plus there is an added cost because these are costly. So a little bit about what is a conventional nasal pack. So all of you must have seen these packings done in ENT departments, and these diagrams similar to these in textbooks. So it is usually half-inch ribbon gauze that is soaked well in Polyfex, and then it is placed in the nose in layers. So if you have to do nasal packing, what you need is, you need a headlight, you need a nasal speculum, you need a forceps, and the most important, you need practical training in nasal packing. If you have not done it before under supervision and you are not well versed with it, you cannot go read a book or see a video and start doing nasal packing, and I will show in a while why that is so. And then we have new non-absorbable nasal packs which are really nice. So this one is Miroseal. This is a sponge-like material. It is thin. When you place it in the nose, it absorbs blood and then it swells up and then places compression on the bleeding site. And then there is the Rapid Rhino. So it has a cuff similar to the ETT cuff. You instill saline in it and it causes swelling of the pack. So it is, these are easier to place and easier to remove and less uncomfortable as compared to the conventional nasal pack. And then the absorbable nasal pack. So these are available as sponge stone or Surgispon. So usually these are so they are pre-made for the nose, but usually you will have these in your stores which are rectangular in shape. So you can divide them into in the middle and then apply Polyfex around it for lubrication, and then you can insert it in the nose. So very beautiful diagram of the nose. So this is the anterior nares. So that is what you see when you are doing nasal packing. So it is for someone who has not done nasal packing before, or someone who is not very well versed with the anatomy of the nose. It is a tendency to insert the pack in this direction. So, and if you are doing a conventional nasal pack and you have a metallic forceps in your hand and you are putting a ribbon gauze and you go like this, and here you will go into the brain. So that is why it is conventional nasal packs should not be done by someone who is not trained. The absorbable or non-absorbable, they are easier to place and they can be placed. So the idea is that you follow the floor of the nose for nasal packing, and you can visualize it. It is along the roof of your oral cavity, and the pack should go like this. Here you can see they are placing Miroseal. So, and this is how it should be inside your nose. So this is quite easy, and someone who has not done it before can actually do it very easily. And then the statement number 4 is nasal packing education. So this is very important. So many times in the ER you encounter a patient who has a nasal pack and you don't know what it is, what is the size, what is the material, and how long ago it was placed, and what was the plan of the primary physician doing that nasal pack. So whenever you do nasal pack, always remember to inform the patient that what is the type of pack, whether it is absorbable or non-absorbable, and what is your plan for removing it. And so in case he lands at some other ED or some other place So he can tell his physician that what was the pack and when it was supposed to be removed. This will help in avoiding prolonged packing, which has side effects including infection and toxic shock syndrome. And it is important that prophylactic antibiotics are explained to the patient if they are needed. And again, what I have already said. So now statement number 5 is on risk factors. Whenever you have a patient who presents with history of nosebleed or with active nosebleed, always document possible risk factors so that they can be addressed timely. And this includes hypertension, use of anticoagulants, use of antiplatelets, a family history of bleeding disorders, and use of intranasal drugs. So once you have done the nose pinch and the bleeding has stopped, the next what you need to do is you need to visualize, you need to see where the bleeding site is. You might have to suction the clot and do an anterior rhinoscopy. And then comes the question, when do you need to do a nasal endoscopy, or when do you need to refer the patient to a facility where a nasal endoscopy can be done. So a patient who has recurrent bleed despite packing, despite cautery, it is not resolving, the patient definitely needs a nasal endoscopy. Then a patient who has unilateral recurrent nasal bleed, he definitely needs an urgent nasal endoscopy. So you can identify posterior bleeds because it is the posterior bleeds that are usually not controlled with our first line interventions, and then you will also rule out an nasopharyngeal pathology, and then you can start the appropriate treatment as per the site. So what are the appropriate interventions at that bleeding site? So the guidelines do not specify one, they do not give a sequence, they just list them all. So they include topical vasoconstrictors, we all know these. They include nasal cautery. So it can be electrical cautery, it can be chemical cautery. So chemical cautery is easily available. You can get it from the pharmacy and you can do it at bedside if you have head light and nasal speculum. And then lubricating gels. So lubricating gels include Lectrilube, Polyfex, Fusidin. You can use any one of these. So there are just a few points that were not included in the guidelines, but I just wanted to touch upon them very briefly. One is the use of topical tranexamic acid for epistaxis. So the guideline does not address this at all, and these days we are seeing its used very commonly in the emergency department. Yes, there are studies and they are coming. So this is one systematic review and meta-analysis that is very recent, last year in January, and it has shown that the topical tranexamic acid is associated with better bleeding cessation after treatment compared to standard practices. So they included a lot of clinical trials that had placebo and tranexamic acid, and they did show an improvement in control of epistaxis. The second is role of coagulation profile. So it is still, I guess, a controversy. Whenever a patient comes in the ED, all the ED physicians, they do a full coagulation profile and CBC. So this study actually is from Pakistan, from Aga Khan University. And they did a retrospective study to see if the coagulation disorders were present in those patients who had epistaxis, and they found out the gist of the study was that only in those patients who were taking anticoagulation, these studies were useful. In all other patients, they were not useful. Most of the patients did not have deranged coagulation profile with epistaxis. And lastly, some personal recommendations for anyone who is responding to epistaxis. So the most important assessment is the heart rate and pallor of the patient. Before you check the blood pressure, before you have a CBC, you need to see if the patient has a high heart rate and has pallor, then the patient might have lost a lot of blood, and you need to be really quick and do everything very timely. Always start with topical vasoconstrictor and pinch the nose. Pinch the nose for 10 minutes, because if you are pinching the nose, it is very hard to continue pinching for 10 minutes and 1 minute seems like an hour. So you have to look at the clock and wait for 10 minutes, because pinching for less than 5 minutes is almost never effective, and for 10 minutes is almost always effective. So if the patient comes to the ER or your OPD and you do this and bleeding resolves, Then advise the patient to avoid nose picking, because nose picking is the most common cause of epistaxis, especially in children. Advise the patient to use lubrication for at least 2 weeks. Give them normal saline nose drops, which will also lubricate the nose for 2 weeks. And I think everyone who has to see a patient with epistaxis should learn how to use a Mirosil or sponge stone, and it is very easy. And so yes, so that's it. Thank you.